All right, we're going to go ahead and get started. Welcome, everyone. My name is Lauren Becker, and on behalf of the National Association of Community Health Centers, I'm very excited to welcome you to today's Million Hearts Learning Lab. A statin is indicated for your patient, getting there together. Before we jump into our great speakers, I do have a few quick reminders for you. Today's Learning Lab is being recorded, and we will send it out to all attendees after this call. All attendee lines have been muted and the chat has been disabled today for this webinar. Instead, we invite you to submit your questions for our speakers through the Q&A function at the bottom of your screen. You can also upvote and comment on questions submitted by other attendees if you would like to participate in the conversation. The Million Hearts Learning Lab is a joint effort between the Million Hearts Initiative at the Center for Disease Control and Prevention and the National Association of Community Health Centers. And it consists of three parts. There's a brief pre-work video and a quick survey to collect questions for our speakers. And then this live 45-minute webinar that you're attending today. If you didn't get a chance to watch the pre-work video, we will go ahead and drop that link in the chat right now. And we will also send it out with the recording of this session. Our learning objectives today are to identify activities and policies that can be implemented to reach high-risk groups, review data identifying missed opportunities for statin prescribing among high-risk groups, and discuss the role of patient and clinician education that patient and clinician education can play in statin prescribing for high-risk groups. Before I begin today, I just have a quick disclaimer before I introduce our moderator. The opinions expressed by the speakers in today's Learning Lab do not necessarily reflect the opinions of HHS or CDC. And so now I have the pleasure of introducing our moderator, Hillary Wall. Hillary is a senior health scientist at CDC, and she also serves as the science lead for Million Hearts. She has over 15 years of experience in cardiovascular disease projects related to surveillance, applied research, research translation, evaluation, and communication. Welcome, Hillary.
Thanks so much, Lauren, and welcome everyone. I am so happy to be with you all today as the moderator for this session. And if we can go to the next slide, I just want to remind everyone that although we here at Million Hearts spend a lot of our time talking about blood pressure control, cholesterol management is definitely second on our list of best buys for preventing acute cardiovascular events like heart attacks and strokes. Next slide. So I would love to just take a brief moment to recap some of what you heard during the pre-work video. And if you hadn't had a chance to watch that video, you've got the link in the chat. My colleague here at CDC, Dr. Angela Thompson-Paul, shared results from one of our recent publications on statin use surveillance. And what we found is that among people who are recommended to take a statin per the 2018 ACC/AHA guideline on the management of blood cholesterol, statin use, frankly, is suboptimal. And when we talk about being recommended to take a statin, what we mean is that there's a class 1A or B recommendation for its use. So that's strong evidence from high or moderate quality studies. And over 50% of people for whom it is recommended are not currently taking any statins. These are the people for whom statin use should basically be a given. And so today we're really going to focus on supporting statin use in this population, but I want to take a second just to mention that there are another 50 million people or so indicated on the slide in the gray for whom, per the guideline, statins should be considered. And so these are folks who have elevated atherosclerotic cardiovascular disease risk or ASCVD risk. You'll hear us talk a lot about that, or what's referred to as risk-enhancing factors. So we're going to focus on the green population, but don't forget about the gray. Let's go to the next slide, please. So let's look at our populations who are at highest risk for an ASCVD event. Among the almost 18 million people with clinical ASCVD, and these are people who have had heart attacks, had strokes, TIAs, CABG procedures, PCI or angioplasties, peripheral artery disease, and other conditions, we've got 4 out of 10 of these people who are not currently taking a statin. And again, this is statin use for secondary prevention. 4 out of 10 not taking a statin. Then we have another 5 million people who have what we call severe hypercholesterolemia. That is LDL greater than or equal to 190 milligrams per deciliter. Less than 1 in 10 in this group are currently taking a statin. Of the 20 million people or so with diabetes, about half are not taking a statin. That's 10 million people with diabetes who could benefit from taking it. And lastly, we've got 4 million people with greater than 20% 10-year risk of ASCVD. 2/3 of that population are not currently taking a statin. So these collectively represent millions of opportunities for additional clinical attention to prevent ASCVD events. But I want to recognize that this is national surveillance data we're talking about. I'd like to bring it down more into the clinical setting. And so for the past 5 years, Million Hearts has worked with the National Association of Community Health Centers and 25 health centers from 5 different health center controlled networks to explore opportunities for increased statin use among these high-risk populations that you see. And we explored electronic health record data in these health centers to find potential gaps in care related to statin use. And I'd like to share some very, very high-level findings from 4 health centers, just an excerpt of our data. And next slide. So for the population of health centers, for the population of health center patients with clinical ASCVD, we found that younger adults were much less likely than older adults, Black adults were less likely than white adults, and women were much less likely than men to be prescribed a statin. And for the population with severe hypercholesterolemia, you can go to the next slide. Younger adults were much less likely than older adults to be prescribed a statin. And you can go to the next slide. For patients with diabetes, younger adults, Black adults, and uninsured adults were less likely to be prescribed a statin than their respective comparisons. So we hope that you leave here today with a renewed understanding of the importance of prescribing statins for your patients who are at risk for ASCVD events, and get tips for how to have those shared decision-making conversations and just better support statin prescribing in your clinical setting. So next slide. With that, we have 2 amazing physicians joining me today. I'm so excited. They're here to share their expertise and all their wisdom on this topic. First, we have Dr. Lawrence Sperling, known as Larry to many of us. He is the Executive Director of Million Hearts. He also is the Katz Professor of Preventive Cardiology at the Emory University School of Medicine and Professor of Global Health at Emory's Rollins School of Public Health. He also served on the writing committee of the 2018 ACC-AHA guideline on the management of blood cholesterol. And then we also have joining us Dr. Danielle Oren, who is a family medicine specialist and currently serves as the Chief Medical Officer for Aliados Health and Chief Medical Informatics Officer of Petaluma Health Center. And Dr. Oren provides leadership and support for initiatives in clinical systems, health information technology, and quality. So we've got a wide breadth of expertise to tap into today, and I'm really excited. Larry, Danielle, thank you, and welcome. So, and are we on camera? I can't see you guys. There we are. All right. So let's just jump right into questions if that's okay. I just shared with you a bunch of national surveillance data, and I'm just curious. I'm going to ask both of you this question, but maybe Dr. Sperling, you can get us started off. What do you think accounts for our nation's current performance related to appropriate cholesterol management?
So Hillary, first of all, your introduction to today's Learning Lab was so critically important. I was definitely not a math major, but what caught my attention were 24 million missed opportunities. We know that Million Hearts focuses on building healthy communities, optimizing care with a core focus on health equity. The optimizing care is all about our ABCs. ABCs are implementing proven and effective strategies to prevent heart attacks and strokes. I think the challenges we have are many, to be honest. Our healthcare delivery is fragmented, episodic, and catastrophic. It takes a long time for guidelines to move into practice. We know that. Our clinicians are really strapped. They want to do well. They're committed to doing well. They're committed to care of their patients. But there are time challenges, there are system challenges. And clearly, we need better partnership and we need team-based approaches. Medicine has changed dramatically, even in the last 5 or 10 years. So I don't think I could put my finger on, one challenge or problem. There are many, but these missed opportunities, and we'll come back to those where statins are clearly recommended, not even considered, those 4 statin benefit groups. If we can do anything as clinicians and health systems, it's focusing on these opportunities for care.
Right, Danielle?
Sure. Maybe I'll just add to that, some of the challenges that we see are, from the perspective at the community health center is access to care, getting people into care is always a challenge. And I think that gets to what you were sharing, Larry, about the system, but also speaks to some of what we're challenged with generally at FQHCs, which is difficulty meeting demand, getting the right people into care when they need it. So definitely engaging people. And then I would say once, having systems that help us to manage our time in such a way that we can actually address some of these issues when people do get into care because of the issues with getting the right people in to the right kinds of interactions. It's often challenging to get to the issue of the statin. Did you even know that you were going to need to address that today? And getting to it after potentially a long list of other things that might be more acute, for sure. So, and then of course, everything that follows thereafter, the follow-up and the, making sure that all of those things happen. And then lastly, of course, making sure that the providers that are interacting with patients are up to date on all of the the correct recommendations and feel empowered and have the tools that they need to take action on them.
And any thoughts about screening? Are we doing really well for cholesterol screening in this country?
No, I mean, definitely getting the screening testing done also relies on all of those same things. So I think we're probably challenged in the exact same ways.
Yeah.
Yeah, and I'm just going to add there that the guidelines recommend that all Americans, not just those at risk over the age of 20, have a lipid profile done once every 5 years. And of course, those at higher risk, not only should we be screening, but we should risk assess. And for those at highest risk, we don't need to risk assess anymore. It's time to start a statin. Begin that conversation. That conversation isn't necessarily a one-off. I think that's where a lot of clinicians, miss those opportunities. And it's just when we see a patient who clearly statin is indicated for, and the title of our learning lab, indicated and together, right? So find those where statins are indicated and then create a trusted and safe partnership. Start the conversation. The conversation doesn't have to happen, and finish in 15 minutes. I frequently start the conversation, and you want to be paying attention to the person on the receiving end. And if they are, a little hesitant, I might just have that conversation and say, talk about statin benefits. Of course, consider side effects. But if I were going to prescribe a statin, I'll write it down on a piece of paper. Here's the medicine, here's the dose. Think about it and let me know. And then either have your team follow up, or I ask the patient to follow up with me by our electronic medical record communication system. And so many times they message back and say, I thought about it, and go ahead and prescribe it. So don't feel rushed. Don't feel like this is your, one opportunity to either prescribe or not prescribe.
Those are really great points, Larry. And I love the idea of continuing the conversation through the patient portal or other electronic means like that. So Danielle, you're very, on boots on the ground in health centers, helping health centers. How do you speak to, what's your process for identifying those opportunities to speak to patients about statin therapy? And does your team come into play? What does that look like on a large scale?
Sure. For both our health center controlled network and the health center I work at, which is part of that health center controlled network, we started with configuring care gaps. So, basically using our population health management platform to surface for the care team on the day of any visits, any patients who should be taking a statin, who are part of any of those 4 high-risk groups. So one care gap would be related to the first 3, those with diabetes, those with known heart disease, and those with LDL greater than or equal to 190. And then another one that's related to the ASCVD risk score, and also making sure that that risk score is really visible on that care gap list for the care team to see. And then at our health center, at Petaluma Health Center, we have a huddle before each shift involving at minimum the provider and medical assistant that are going to see that patient that day, but also often includes the care team nurse and other members of the care team. It could include referrals, case management, people like that, where we actually make a plan for the patient for the day. And included in making that plan is reviewing all of the care gaps. So if a care gap came up and said, you should have a discussion with this patient about starting a statin today, we would make a plan around that. First, I would check and see, did I already discuss this before? Is this a continuation, or is this a new conversation? Do I need to leverage other team members? Is this someone who might qualify for, we have a pharmacy clinic with a clinical pharmacist who helps people to that are a little bit more resistant to starting a statin, really walk through the risks and benefits and understand the pharmacology, more, in a more in-depth kind of way. They have a little bit more time. So trying to really match the conversation with the patient if we know them. And if it's a beginning conversation, then plan for that. And then we put that on our agenda for the day, and we make sure that gets addressed before that person leaves.
That's great. And Danielle, I know you're this informatics guru as well, and I have a deep appreciation for informatics. What opportunities to bring in health information technology and health systems approaches to bridging these gaps exist?
Sure. I mean, I think, I definitely think that making sure that people who are coming in don't leave without some kind of conversation or intervention is definitely one of them. So configuring care gaps, and then making sure that there's actual time set aside to address them, because as we discussed in the opening, time is a definite issue. Beyond that, using those same tools, configure quality measures, configure lists of patients that can be outreach to. I know that we also use our pop health system to do automated outreach, both for, we may send a message, an educational message, or we may send a message saying you're due for follow-up, or you're due for screening. It seems like you should have a cholesterol test done. We've written an order, just go to the lab and do it. So trying to automate some of the things that need to happen, and see if patients will respond to text message or portal message to get them to engage in that way. I think those are some of the ways that we've been exploring doing that.
Yeah, that's great. Dr. Sperling, anything to add related to technology?
Yeah, just an example. We talk a lot about AI and big data. We have opportunities within our health system to gather this data. The challenges are implementation. Just like on the front end, even if we can gather the data on the back end, we need to work through our teams and our systems, importantly through our clinicians and those we serve, our patients and their families, to not only implement, but maintain and message the why. An example, Emory is one of the 5 sites in the country that's part of the Find FH initiative. And we can find, with a very high likelihood, every single patient in our system with probable familial hypercholesterolemia. All of a sudden, we flip the challenge, though. As opposed to finding one patient at a time, talking to them and their families, we find them. Now the challenge is we need our clinicians to be well educated, how to message, how to partner together. And we also need to have the right messages and communications for those who are found with FH. So the possibilities are out there, but it comes back to, instead of AI, I call it HI, human intelligence.
I love that. Go ahead, Daniel.
Sure. What you're saying made me also think about that there's also opportunity for health centers who often in that first group, the patients with ASCVD, oftentimes we may not have that diagnosis in our EHR because that diagnosis is often made at cardiology or in the hospital. And so getting that diagnosis is definitely something that we can do. This same kind of data mining for us, we've been working on getting it from HIE and from claims data. So trying to surface more eligible patients in that way.
That's such an important point because we learn how to, I guess, abide by the electronic record. And those of you who care for patients know that all that's in the electronic record is not true. So be a cautious skeptic. And one of the sayings I use with our house staff is frequently just, when in doubt, ask the patient, right? We still need to communicate.
So I'm curious, with these sort of population health management techniques or the AI, how acceptable is that to clinical staff when you share those data? Are they well received, or is it a lot of the skepticism, Larry?
Yeah, so the answer, and I'll be interested to hear what Danielle has to say here, is, we as clinicians all think we're doing well, right? We think 90% of our patients where they're high risk and have a statin that is indicated are on statins. So we don't know until we ask, and we don't know until we're told. And so an opportunity through health technology is honest reporting. It can be, just to us, or anonymous reporting for us and our colleagues, or one system versus another system. But what gets measured, at least we're aware. And often what gets measured, we realize the gaps and opportunities. So I would think, and I can't speak for anyone other than myself, but I would think most clinicians would welcome honest feedback on how they're doing.
Yeah, that's been my experience, is mostly positive, and most the care team members, including the clinicians, have found it really helpful to have. Occasionally, there'll be a patient who's already on a statin because they were diagnosed outside and put on a statin and we didn't know about it. It's still an opportunity to have that conversation and put it on the medication list and make the record reflect what it should be anyway. So mostly, I would say, very positive response to this.
I think another point here is we also don't treat electronic medical records, we treat patients. And so even if it's the right statin is on the chart for the right patient, we need to ask. And one of the first things I do is, the guidelines tell us in the top 10 take-home messages, message number 10 is we need to assess adherence and percent response. And frequently when I see an LDL cholesterol higher than I would expect in a patient, let's just say somebody with ASCVD, and I look at the chart, they're taking the medicine's prescribed. My first question is often, how many times a week or month, in a non-judgmental fashion, I ask, how many times a week or month do you miss taking your statin? I've asked that question many times, and you get really interesting answers, to be honest. Sometimes, oh, they're every day on the week, but not on the weekends, or not when I'm traveling. So frequently the opportunity just to talk about adherence. And then the flip side of this, on our end as clinicians, we call therapeutic inertia, right? It's easy to toe the line. And, sometimes we fear having those conversations, not because we fear the conversations. we fear the time related to those conversations. That's the honest truth. Is you're behind in clinic. You should be having this conversation with this current patient, but you're 30 minutes behind, and this patient's going to have a lot of questions.
Is that an opportunity to bring in other care team members who might have a little bit more time?
Yeah, I certainly think so if they're available. If you have case managers, health educators, community health workers often are a good source. And at Petaluma Health Center, we also use our pharmacy students and clinical pharmacists in that manner. A lot of the patients that we're talking about here are on lots of different medications, and a lot of their concerns may be related to how is this going to interact with that? And I also have diabetes. Do I need to worry about that? And so definitely always looking out for opportunities for other care team members to do their part of it as well.
Great. So I keep hearing time. Time is an issue when it comes to cholesterol management, which is interesting. It's not up there on the priority list, and there are so many priorities that are on that list, unfortunately. I'm going to turn to a question we received from the audience. Our participant asks, what kinds of data might be helpful for providers to manage high-risk patients from getting data from a quality improvement department? What are the key motivating factors for the providers working in particularly an FQHC setting?
Sure. Maybe I can share what we provide typically to providers within our population health management platform. Always visible to everyone, unblinded, is performance on the standard HEDIS-like statin measure, the same one that we're reporting to for UDS. So that's broken out by provider, and anybody who's using the system can dig into that in a number of ways and sort by race or ethnicity or language, site, care team, and so on. And then we also allow that to be drilled into, so you can quickly, if I was looking today at my own patients, I would drill in and say, I'm only at 60%. Who did I miss? And so then I can quickly see a list of patients. And if possible, it's always nice if there's time for the care team to work together on that list and say, who are these people? What are the possible barriers? Who should be reaching out to them? And how can we engage them in care? And then, arrange for them to have time with the right care team member to discuss starting a statin if that's really what's appropriate for them.
And Danielle, just a follow-up, are clinicians in your health centers able to benchmark either against each other, or is it just they see their own data and that's it?
In our system, everything is completely unblinded. So at the health center level, you can see by care team, by location, and by provider. And it's everybody's in a list together. We see each other's performance. At the health center controlled network level, we also provide that. We display it automatically at the level of the health center. And then if they want to, they can also get down to the level of the provider there as well. And that's available to QI directors, chief medical officers, medical directors, CEOs, leadership teams at health centers to, if they wanted to, say, identify another health center in the network that had great performance to see what they were doing, that would be something they could do that way.
That's great. And we do have another question that came in. I don't know if you two can speak to this, perhaps for California and Georgia. Wesley Hicks says, in Colorado, community pharmacists can assess and prescribe statin therapy via a statewide protocol. And I love this idea, but I know not all states can do that. Is that something that's being considered in other states as well? Is that a California or Georgia thing?
Not in place in Georgia at this time. Hopefully being considered in many places. Really valuable contribution to patient care and to the care team. We do have a PharmD and a specialty pharmacy clinic connected to our Center for Heart Disease Prevention. And they are able to, with physician supervision, prescribe medications. And they certainly are able to have these conversations that we talked about that take time. And as Danielle mentioned, they frequently are working with students, and students, not that they, have an abundance of time, but frequently have more time than the clinicians with the boots on the ground.
Love that. So I'm going to switch gears a little bit. We've been talking a lot about statins, but lifestyle modifications certainly is a big part of the clinical guidelines. And so what do you say to clinicians or patients who want to try lifestyle modifications first before starting statin therapy? Is that appropriate? Is that a good approach?
I can start. A lot of this depends on the risk of the patient. Of course, in each and every patient, with each visit, we should be talking about lifestyle and behavioral approaches and opportunities to improve many different cardiovascular risk factors. My patients know that I'm going to ask them about their home blood pressures, their physical activity, or sometimes lack thereof, their dietary patterns. And, for those that are smoking, they know at every visit I'll be asking, not telling, importantly, I'll be asking. For those that are high risk, we're going to come back to the pre-work video, because that pre-work video has a very strong message. And the strong message is 50% or more of the high-risk individuals are not on statins. And so in those who are high risk, certainly I'm going to be talking about a lifestyle behavioral approach. But for those at high risk, that's not enough. And although we reference statins as cholesterol-lowering medications, and they do through their mechanism of action or mechanisms of action, statins are medications that reduce the risk of heart attack, strokes, and cardiovascular events. So it's not about just treating the number, it's treating the patient and conveying that message that medicines, in addition to the lifestyle and behavioral approach, are what we need together to prevent you from either having a primary event or future events.
That's great. Danielle, any additional thoughts?
I think I take a very similar approach of starting with the explanation that that's not going to be enough, that it's very important. And yes, all of the lifestyle changes are needed, but that to really reduce their risk, that statin would be important. And sometimes that's enough of a conversation, and other times we have to have continued conversations and dig further into the why they are not wanting to accept one right off the bat.
That's great. We've got another question from participants. James Bennett says he's a pharmacist working as a medication therapy management specialist via telepharmacy. Love that. When he spots a gap in care, for example, a person needs a statin, he talks to the patient and asks them to talk to their PCP. His other option is to fax a request to the PCP. He's wondering, what are your thoughts on putting the patient in charge of driving their own care by speaking with the PCP?
I can start here. Certainly informing patients, empowering patients, having the patients understand the why about that medication and the importance of the medication. So I fully agree. Patients can bring in a list of questions to their clinicians for their clinician visit, be prepared. We have many ways to touch base with our clinical teams today, through electronic portals or requesting a telehealth or telemedicine visit for a conversation. So I'm all for it. But it does need to be bi-directional, right? The clinicians on the receiving end, they need to understand the why, just as the patients understand the why. And, you know, if we get that synergy, we begin to close those gaps.
That's great. And we're wrapping up rapidly. We're coming to the end of our time. But Danielle, maybe I'll ask this question to you. I feel like sometimes when I'm in conversations about statins and cholesterol management, there's sort of an elephant in the room about statins and whether they're safe to take. Like, do you have any thoughts on, we sort of touched on this earlier, but are statins safe? Like, what should we be telling patients there?
Yeah, I think there's some really nice resources. I see that we have the lifestyle in the chat, but there are some nice resources. I think there's an FAQ from NAC that I like to pull out every now and again that goes through the main concerns that that patients typically have that I like to use to walk through. That's definitely pretty helpful in walking through how safe they really are. I typically try to use some of the resources to explain that they are safe to take.
Larry, any additional thoughts?
Absolutely. Patients are concerned about statin side effects. If you go to the internet and look up statins, frequently you're going to find, you know, a lot of list of side effects. So we need to be aware of that. The section in the guidelines is specifically titled Statin Safety and Statin Associated Side Effects. Statins are among the safest medications we prescribe, first prescribed or FDA approved in 1987, among the most studied of any medications. So when patients ask, we want to start with, as opposed to debunking the myths, we want to emphasize statin truths. Statins work. Statins are safe. Statins prevent heart attack, strokes, and cardiovascular events. Statin side effects in some people are real, so we shouldn't negate that. The typical statin-associated side effects, the most common for clinicians, is called SAMS, statin-associated muscle symptoms. That's when bilaterally the large muscles in your body ache, feeling like you have the flu, but you don't. So when somebody's shoulder hurts, ouch, their shoulder hurts. It's not likely from the statin. So certainly listen to your patients. Don't tell, don't negate, but build trust. In the majority of patients, you will find the right statin for the right patient. And that's how I approach it, that we're going to find the right medicine for you. Sometimes it might take a little time to find the right medicine or the right dose, but we will find the right medicine. And, you know, statins, I don't know how we're on time. I'm looking at, but
Time's up, unfortunately.
All right. So that's my answer. Time's up.
Yeah, no, I really appreciate those thoughts. And you two have you're such a wealth of information. I feel like we could keep this conversation going for the next hour. But I really pulled some very salient points from what you all said. So we have 24 million missed opportunities to prevent ASCVD events. Statins are safe, effective, and very well studied medications. Statins should be prescribed in addition to lifestyle modifications. And what I heard over and over is that time is a really big challenge for cholesterol management. So for clinicians, don't feel rushed in your conversations. You can have those conversations multiple times, maybe via the patient portal or other means, and try to incorporate care team members whenever possible who might have some additional time. Loved the idea of pharmacy students, or pharmacists, or community health workers, lots of different team members who can support these efforts. So thank you both so much for your time. And Lauren, if we could go to the next slide, please. This has been a very great conversation, and I think we've heard lots of sort of high-level systems changes and different tactics for really supporting statin prescription in clinical settings. I did want to let you all know I'm giving you a little sneak peek here to help support statin use in your patient populations. Million Hearts has collaborated with the National Association of Community Health Centers and the American Medical Association to develop a cholesterol management change package. And a change package, don't let that term turn you off. It's just really a menu of evidence-based and evidence-informed ways in which you can change care processes related to, in this case, cholesterol management. And you may have seen some of our other Million Hearts change packages. As with all of them, we have provided tested tools and resources gathered from clinicians in the field, like Larry and Danielle, or national organizations who care about cholesterol management. So I just want to let you know it will officially go live March 18th. But again, you get the sort of insider information about the fact that it's coming. So thank you all for your time today. And Lauren, I'll turn it over to you.
Thank you so much, Hillary, Larry, and Danielle for that great conversation. I know we mentioned some of these resources, and we're going to put the links in the chat here, but we'll also send them out after the recording. And so I want to take a quick second to highlight 3 of them. The first one being the Treating Patients with Statins, Tips from Clinicians to Clinicians, which is a clinician education video. And then we also mentioned during our conversation both the Million Hearts Common Patient Questions about Statins, which is a Q&A document, as well as the next bullet down, the Statins and Lifestyle infographic. And so highly recommend that you check those out. So our next Learning Lab is going to be on May 16th, 2024. This is a new date, and it's going to focus on short-term interventions with high impact to improve hypertension and cholesterol management. And we're going to drop a link in the chat to register for that as well if you haven't done that already. And we certainly hope to see you there. And then lastly, to receive CE credits for attending today, you can visit the link that will also be dropped in the chat for the CDC Train website. And if you search for the Million Hearts Learning Lab on the Train website after you've registered, and you enter the code statin therapy with no space, you can complete the post-assessment and the evaluation, and then follow the instructions for accessing the certificate and the transcript for the course. And you can see the eligible CE amounts below listed on the slide. And thank you all so much for your time today. And we certainly hope to see you at our Learning Lab in May.